recording. Okay. All right. So we're going to get started now. Welcome again to our annual supporters meeting for 2024. Today, you'll see the agenda in front of you. We're going to start with Jim Parks, our president, who will provide some opening remarks and introduce the board of directors and provide some awards for people that deserve recognition. I'm Tom Gottlieb. I'm the treasurer. I will be providing a treasurer's report after that. And then we have Dr. Michael Balas to provide our 14th annual Albert Waxer lecture. The highlight of our supporters meetings in the past have been our question and answer session. So you get to ask any question you like, whether it be on the lecture topic or anything else to do with glaucoma that you want to ask our experts, our expert panel. Please feel free to do that. You don't have to wait until the question and answer session starts. You'll notice in the top right of this window a little icon that says Q&A. So anytime during the session, up to the question and answer session, and even during the panel session, you can post a question there by clicking that icon. You should find it at the top or the bottom of your screen. And click that, type in your question, and we will try to get to it as efficiently as possible. So with that, I'm going to introduce Jim Parks. Jim, I'm going to put you on the screen, and you have the floor.
Okay, thanks, Tom. Just to reiterate Tom's welcome, I echo that. Welcome to all those who are joining us, and thanks for taking the time on a night when you can probably be doing other things to listen to what we have to present. We've been doing these for quite a while, and as Tom indicated, we have an agenda that we will be following. So my role at the beginning is just to give you a little bit of background. Most of you probably know that the Society is a federally incorporated company that is without shares. That means it has members, not shareholders. It's registered with the Canada Revenue Agency as a charity. It has audited financial statements every year, and a fairly obscure point, in Ontario as a charity, it is ultimately accountable, as are the board of directors, to the public guardian and trustee, which is an agency of the Attorney General that makes sure charities do what they're supposed to do and don't misapply their funds or otherwise get off the rails. We send out newsletters in the spring and the fall. Our website has been updated. It's very much up to speed now. And we hold seminars, or webinars, I should say, periodically about various matters of interest. So that's sort of what we do as our outreach. Overall, of course, our main role is to raise money so we can make grants to researchers. So more will be said about that later. So as a matter of governance, we currently have 11 directors in office. They're all volunteers. They come from a variety of backgrounds. We're fortunate to have 4 glaucoma specialists, which will be evident as we go through the slides. So Tom, if you could just start scrolling through those, please.
Yeah.
That's me. I'm a lawyer. I'm the president, and I give unofficial legal advice pro bono when necessary to the society, and I chair the meetings of the board and the members. Next up, we have Martin Chasen, who's the past president. He's an accountant and has been instrumental in a lot of the financial stuff, including changing our year end from May to December, which has been very beneficial. And he also provides input on issues relating to charitable giving, tax benefits, etc. Next, we have Tom, who you just heard from. Tom's a professional engineer. He's our treasurer and has been extremely busy and doing a lot of stuff. I think probably more than any of us individually, and dealing with a whole bunch of things, including financial affairs, and you'll hear more from him later with his report. Next, Mark Schaefer is a family doctor, forensic medicine, been on the board for a number of years. He's our executive secretary and was instrumental in getting us involved in what was originally the Downtown Marathon and is now the Walk for Research, which we'll be holding on next Sunday as a significant way to raise funds. Next, Dr. Graham Trope, known to all of you, I'm sure, the founder of the society, a specialist in glaucoma, world leading specialist, I should say, now retired, unfortunately, from our perspective, but still active on our board and chair of our scientific advisory committee. You'll hear more from Graham later. Next is Dr. Catherine Burt, also a glaucoma specialist, the vice chair of the scientific advisory committee, and has been past president of the Canadian Glaucoma Society and has been involved in some of those webinars I mentioned. Next, Dr. Rajiv Bindlish, another glaucoma specialist, who heads up our question and answer session and has given some of the webinars as well. You'll hear more from him later during the question and answers. Next up is Dr. Cindy Hutnick, yet another glaucoma specialist, also a past president of the Canadian Glaucoma Society, and she's been quite involved in a lot of research through organizations in London, Ontario, and she'll be on the question and answer session as well. Next, Dr. Quinter, not Dr. Quinter, Alf Quinter, lawyer, not a doctor, involved in personal injury and finance. He also gives legal advice as necessary to the board. Next is Scott Leslie, a businessman involved in pharmacy businesses with a strong background that's been very helpful to the board in liaising with pharma and related industries, developing strategies, etc. And then Stuart Murray, an accountant who has been very involved in upgrading our website and providing other IT and useful advice on that score. So that is our board of directors. As I mentioned, they're all volunteers. Tom will make a few comments when he gives his report about the diversity that we're fortunate to have on the board. I'll now skip to my second job, which is to deal with annual recognition awards. These are something we've done for many years. We try to recognize contributions from various supporters, some corporate, some individual, some charities in some cases. So the first one is Geek Power Inc., which has been very helpful to us throughout many years, particularly with upgrading our website. And as I mentioned, Stuart has headed up a lot of that work. So we're fortunate, I think, to have some of the Geek Power people on the meeting tonight. And I'd just like to express to them our thanks in person for your very useful and helpful contribution. Next, Susan McNeil, for her very generous contribution as well. Next, Gail Wilson, also in recognition of her generous contribution to the society. Thank you very much. Alexandra Mendez, also a recognition of her generous contribution. Thank you. And Cameron Beatty from Cambridge Toyota for his very generous contribution as well. Thank you again. Here I'm going to go slightly off topic and say that we have another award which isn't on your screen, and I'll explain why that is in a second. As I mentioned earlier, Tom Gottlieb, our treasurer, has just been super involved over the last year. And so without letting him know it, we decided to give him an award. So you won't see his picture, but you did see it previously. Tom, I suspect you probably would have said you didn't want it if we told you we're giving it to you, but you're getting it anywhere. Anyway, I should say, and thanks for all your help. Very much appreciated. And on that note, I will turn it over to Tom, who can carry on with his report.
Okay. All right. Thank you very much, Jim. I hope you can all hear me, right?
Yep.
Okay. So that was a bit of a surprise. I probably would have said, don't give me any award, but thank you. Thank you very much. I've been with the society for about 7 years now. Time just flew by. I can't believe it's been 7 years when I made the mistake of walking up to Graham at one of the annual supporters meeting and announced that I had just retired from my work. And he looked at me and said, "Oh, we need you on the board." So that's how things started with me. But thanks again. So my job tonight is to give you a highlight, give you some background on what we do during the year and our financial picture and how we run the office and all of that. So I'm going to start by summarizing, I guess, what Jim provided as an introduction to the board of directors, just to show you the diversity of skills that we have on the board. Clearly, you wouldn't want to run a research society in glaucoma without a lot of doctors on the board, and we're fortunate to have four glaucoma specialists, one general practitioner as well. So we have the medical area covered very, very well. We have the legal side covered with Jim and Alf, provide us with very sound legal advice, anything to do with contracts, insurance, wills and estates, and so on. They look after all that. We have two accountants on the board, Martin Chason and Stuart Murray. I'm the treasurer, but I'm the token engineer at the bottom. I still get financial advice on financial statements and general ledger postings and so on from Martin. So we run a very sound and tight financial ship. We have all the skills on the board that are required to make sure that that happens. We have Scott Leslie, who's our pharmacy business advisor. He ran an online pharmacy business, knows the industry extremely well, and is very, very knowledgeable in that area, which is helpful for the kind of work that we do. And as I mentioned, that token engineer in the bottom, that's me. So I provide a lot of IT support in terms of organizing office procedures and all that sort of thing. So that's our board of directors. I'd like to provide a shout out to Norlin Roberts. Norlin joined the society almost exactly 1 year ago, just about 2 weeks before last year's annual supporters meeting. So this marks her 1 year anniversary with the society. And I just have to congratulate her for sticking to it and getting done all of the diverse tasks that we've asked her to do. And she came up to speed very, very quickly. We could not run the office without her. She's the friendly voice on the phone. If you call with a question, with a concern, if you want to make a donation on the phone, she will listen to you. She will find somebody to answer your questions. She's terrific. Norlin is a extremely honest and moral and spiritual person. She's a welcome addition to the society. She's a member of the International Association of Administration Professionals. You probably didn't even know what that was until today, but now you know. And she's a certified administrative professional as well, which is something you probably didn't know that existed, but she's extremely well qualified to handle the role. So thank you very much for your work. This is something I introduced last year to, there we go. I'm going to see if I can find my laser pointer here. There we go. I think you can see it. There we go. So this is to give you an idea of what we do. We're busy at the society all year long. The office runs 12 months of the year. It's a full-time job for Norland to keep on top of things. So I'm just going to walk through some of the highlights of what we do at the Society, starting in October, because here we are now sitting in October at the annual supporters meeting at the bottom of the screen here. So this is what we're doing now. We've done all the planning for it, arranged the speaker, got all the invitations out. Here you are, and we have almost 100 people on the call right now. So I think that's a great success. On Sunday, we're doing our walk for research. You may have been getting emails about that from some of our walkers. The walk for research I'll talk about in a bit more later. It's a major fundraising event for the year. In November, we open the research portal. What is the research portal? It's a completely separate website that's designed only for scientists, doctors, and researchers, and for people who are evaluators for research proposals. They submit research proposals on the portal. Norland stick handles them, divides them up with the help of Graham on our scientific advisory committee. They get sent out to evaluators for scoring, and then we make decisions about which research grants we want to award. In December, we like to wish you happy holidays. We send out holiday and New Year's cards, and we start getting back the research proposals from the researchers through the research portal. In January, we're evaluating all the research proposals, scoring them, seeing how many we got, and getting ready to make financial awards. February is our financial audit month. We have our auditor. We submit all of our financial records to get our audited financial statements. In March, we try to have a webinar in honor of World Glaucoma Week. So you might receive an invitation for that. It's usually on a topic related to, obviously, glaucoma. In April, we get ready for the spring newsletter. We send out information to all of our subscribers and supporters to let them know what we're doing. In May is a critical time. By the way, this star that's beside 5 of these months represent months in which we have board meetings. So we get together by Zoom. We discuss what's going on at the Society. The May board meeting is particularly important because that's the meeting where basically I determine how much money we have available for research grants. We determine how many grants that we have that are worthy of support, and we make decisions about who gets the money, basically. In June, Norland is very busy processing the research grant paperwork. We have to get signatures from the researchers on what they're doing with the money. They have to agree to a contract and make sure we get the money to the right place and all the checks go out for supporting research. July and August are somewhat slower months. We're still around planning the fall events. In September, we're publishing a fall newsletter, which you should have received recently. If you didn't, you can go online and get it and ask for it. The fall newsletter has the lists of all the topics for research projects that were awarded in the spring and summer. And that brings us back to today, which we are sitting here at the annual supporters meeting in October. So you can see it's a busy time. So what happened in 2024 as far as collection of funds and allocation of funds for research? I look back at a history of the last 4 years, and we have been trying very, very hard to raise more money so that we can provide and funding for more grants. In 2023, we increased the grant, the basic grant amount per project from $20,000 to $25,000, and we've significantly stepped up our game. So some of that was due to increased revenues from bequests and other sources of funds that we were fortunate to receive. So the last 2 years, we've had a much higher amount of money, almost $360,000 this year going out to research grants. And in the last 4 years, we've awarded $1.3 million in research funding. And I think we're very proud of that. I think it's a strong achievement. And these grants are only going to Canadian researchers, to Canadian hospitals and universities. Where do we get our money from? We do 3 mailings a year. The spring newsletter, the fall newsletter, and the holiday Christmas and New Year's cards. One thing you will not get from us, you will never receive from us calendars in the mail. You won't get Post-it notes. We won't send out address labels. We will never send you a cheap pen that doesn't work, and we'll never send you any keychains or any trinkets that you don't really need. All we do is send you information in our spring and fall newsletters, and we like to remind you about who we are over the holidays. So if you care to make a donation over those times, there's always a donation card in those mailings. We receive online donations through our website, and from our website, you can also sign up as a monthly donor. We have quite a few people who don't want to be bothered with reminders about writing a check or giving their visa, but they do want to support the society. And a good way to do that is to just pledge $20 or $50 or $100 a month, and it'll come out automatically from your credit card and to get sent to us on a monthly basis. We do encourage people to remember us in their wills. We hope that you will live a long and healthy and happy life. But at some point, if you wish to think of us and remember us after you're gone, we are welcome. If you could, we welcome wills and money coming in from bequests from estates. You can also donate shares in kind to the society, and there's a significant tax advantage in doing that, because you will not have to pay tax on the capital gain of those shares. And we get the benefit of the market value. So you can think about that anytime that you wish to make a donation. And finally, the 5-kilometer walk for research. We decided to name it the Walk for Research this year because nobody's really running a marathon at our age these days. But we do go for a 5K walk, and it's one of the largest fundraisers of our year. I think I have a slide especially about it. Here it is here. So if you'll allow me, this is a shameless plug for our annual Walk for Research. It's coming up this Sunday. We have already raised over $40,000, which is great. We have a goal of $60,000, but don't worry if you haven't donated yet. You still have time until the end of November to make a donation. You can go to our website, and there's one of the home pages, there's a scrolling banner at the top that allows you to make a donation to our walk. You can see it's a significant amount of money that comes in every year, so it's important to us. Or you can go right to www.glaucomaresearch.ca/walk, and you can choose a participant to attribute your support. One of the board members, we have about a dozen people walking this year, which is a pretty good turnout. So that's all I can think of about the walk. And with that, that's the end of my part. And now I'm going to introduce you to Dr. Graham Trope, who is going to introduce our guest speaker. Graham, are you there?
I'm here. Thank you very much, Tom. Thanks, everybody, for participating and attending tonight. Before I introduce Dr. Michael Balas, just a brief word about Albert Waxer. A number of people have asked me who he was. Albert was on the board of this society for 20 years. And in fact, he was president for 5 of those years. He made very important contributions to the society. He died in 2011, and this lecture series is named in his memory in view of the huge contributions that he made to the Glaucoma Research Society of Canada. Now, to introduce the 14th Albert Waxer Lecturer, and that is Dr. Michael Balas. Michael has a very interesting CV. He has an undergraduate honors in computer sciences. Sorry, it's a undergraduate minor in computer science from McMaster University. He has an honors degree in health sciences from McMaster University. He did so well at Mac that he managed to get into medical school at the University of Toronto, and he qualified as a physician earlier this year. So congratulations, Michael, on that achievement. Michael did so well at medical school that he applied and was accepted to become an eye surgeon, an ophthalmologist, and he's now in training. He's a first-year ophthalmology resident at the University of Toronto, and he's doing research with his mentor, Dr. David Matthew, from the Toronto Western Hospital. Michael has had an amazing career to date. For somebody so young, he has published 50 research articles, clinical and research articles in peer-reviewed journals, which is really quite outstanding. 28 of those articles, he is the first author. This is quite, as I say, outstanding and remarkable, and a testament, hopefully, to the fact that he'll go into academic ophthalmology when he's finished all his training. Michael's interests range from blockchain technology and artificial intelligence in medicine to a review of the side effects of laser treatment for angle closure glaucoma. Michael has given many oral and poster presentations at both national and international meetings, and he has been given many awards, particularly during his undergraduate years. And more recently, in conjunction with Dr. David Matthew, he's received 3 research grants from our organization, the Glaucoma Research Society of Canada. I could go on for another 10 minutes. I'm not going to do so. You want to hear from him, not from me. So I'm now going to ask Michael to come on and tell us a little bit about his research into side effects of glaucoma medications with a focus on the prostaglandins. Michael Balas. Thank you.
Okay. Thank you very much, Graham. So I've put your picture up. Your thumbnail is there. And now I'm going to, I believe that there you are. So you should be able to share your screen, your presentation now.
Perfect. Can you see my slide?
Yes, it's coming across loud and clear.
Okay, perfect. And thank you so much for that introduction, Dr. Trope. I'll try to live up to that. So hi, everyone. I'm Michael, and I am thrilled to talk about our research. First, I'd like to express my deepest thanks to the Glaucoma Research Society of Canada and the opportunity to be here today. And to all the incredible panelists who have shared their expertise throughout the event. It's truly an honor to be presenting the Albert Waxer Lecture. I'm both excited and humbled to share our research today, which wouldn't have been possible without the generous support of the GRSC and its donors. And my hope is that our research will provide you insights that help both patients and clinicians make more informed decisions about their treatment plans. So without further ado, let's get started. So I have nothing to disclose, no conflicts or financial disclosures. And so let's start with the basics. What is glaucoma? Glaucoma is an eye condition that damages the optic nerve, usually due to high pressure in the eye. You can think of it like a clogged sink. The fluid in the eye doesn't drain properly, causing pressure to build up, and this pressure damages the optic nerve. If untreated, glaucoma can lead to permanent vision loss. The good news is treatments exist to manage it. Our job is to make sure that they're used effectively and safely. So as you can see in this diagram, the issue with glaucoma is fluid buildup in the eye. In a normal eye, fluid flows in and out freely, maintaining a healthy pressure. But in an eye with glaucoma, the drainage system gets blocked, leading to an increase in pressure that pushes against the optic nerve, causing damage over time. Left untreated, this damage can lead to vision loss that starts from the edges of your vision and works its way inward. So why is glaucoma such a big deal? Why does it matter? Glaucoma often creeps up on patients without any warning. You don't feel any pain, and you might not notice any vision changes at first. But over time, it affects your peripheral vision, which you see on the sides, and eventually leads to a tunnel vision. If left untreated, it can cause total blindness, and this damage is irreversible. And that's why early detection and treatment are so important. So here's on the left, a visual representation of what happens to your vision with glaucoma. At first, you have normal vision, but as it progresses, your peripheral vision starts to fade, and it can eventually lead to tunnel vision or worse, complete vision loss. That's why it's critical to catch and treat it early. It's one of the leading causes of blindness worldwide, affecting over 80 million people. So who's more likely to develop glaucoma? There are several risk factors to keep in mind. Age is a big one. Glaucoma becomes more common as we get older, especially after the age of 60. Genetics also play a role. If someone in your family has glaucoma, you're at higher risk. Other factors include having nearsightedness or farsightedness, previous eye surgeries or injuries, and prolonged use of steroids. Each of these can increase the pressure inside the eye and put you at risk for developing glaucoma. Now, it's often called the silent thief of sight. Why? Because most people don't notice the early stages. And the reason is simple. It affects the peripheral vision first, which is harder to notice in day-to-day life. Unlike conditions like cataracts, which cause blurry vision, glaucoma's slow progression can easily go unnoticed until significant damage has already occurred. And unlike cataracts, any vision loss that does happen is permanent. So now the good news, glaucoma can be managed. While we can't necessarily cure glaucoma, we can stop it from progressing. Treatments like eye drops, laser therapy, and surgery help reduce eye pressure and prevent further optic nerve damage. Early detection is key, so make sure you get regular eye exams, especially if you're in a high-risk group. And once you start treatment, you have to stay consistent with it. You have to think of it like brushing your teeth. You may not see immediate results, but you're preventing bigger problems down the line. So let's talk a bit about treatment options. The goal of glaucoma treatment is to lower eye pressure and protect the optic nerve. Now, the first line of defense is usually eye drops, which can be very effective. Laser therapy is another first-line treatment that can reduce pressure, and surgery is generally reserved for more advanced cases when drops or lasers aren't enough. The key is to tailor treatment to the individual patient, making sure we're both managing the pressure and minimizing the side effects. And among the various eye drops available, prostaglandin analogs or PGAs are the most commonly prescribed for glaucoma. These medications like Xalatan or Lumigan work by increasing the fluid drainage from the eye, lowering intraocular pressure, and they're generally well tolerated, effective, and easy to use. Plus, they tend to have fewer systemic side effects compared to other glaucoma medications. Now, PGAs are a type of eye drop that have become key players in glaucoma management. They're designed to reduce eye pressure by helping the eye drain its fluid more effectively. Imagine them as a gentle nudge for the eye's drainage system, making it easier for fluid to find its way out. What makes them so popular is that they're also highly effective and usually just need to be applied once a day. The way they act is that they act specifically on what's called the uveoscleral pathway, and they relax muscle fibers to open up more space for the fluid to drain. And so a good analogy is that they're like opening extra lines on a highway during rush hour. The more lanes you open, the smoother the traffic flows, and same thing for the fluid in the eye. As a result, this lowers the pressure inside the eye, which reduces the risk of optic nerve damage and helps preserve vision. They're often the first choice of treatment for glaucoma because they're highly effective at reducing intraocular pressure by about 25 to 30%. They're safe, well tolerated for long-term use, and only need to be applied once a day, making them convenient for patients. This combination of effectiveness, safety, and ease makes them a go-to option for most patients. And while there are a few different options available on the market, they all work in fairly similar ways. You've got latanoprost, branded as Xalatan, travoprost or Travatan, and bimatoprost or Lumigan, among others. And while the names and formulations might differ, the effects and side effects are all quite similar. They're like an all-star basketball team. Each one is great at lowering eye pressure, and your doctor can help choose the best one for you. So let's start by clearing up a few common misconceptions about these PGAs. Some people think they're dangerous. They're actually quite safe when they're used correctly. Another myth is that you'll go blind if you miss a dose. Missing a single dose isn't a catastrophe, but consistency is important for long-term management. And lastly, while they can have side effects, most of them are pretty mild or cosmetic, like changes in eyelash growth or skin pigmentation. And we'll be going over all of those. And this, since we have a large audience of what I assume many of whom have glaucoma, I like to always just review best practices in terms of putting in eye drops. So if you'll bear with me, step one, I think it's important, wash your hands first, tilt your head back and look at the ceiling. Then you use your index finger to pull down the lower eyelid to form a pocket and gently squeeze a single drop into that pocket, making sure not to let the bottle tip touch your eye, your fingers, or anything else. You want to keep it clean and sterile. Then you gently close your eyes and lightly press on the inside corners of your eye. And this is to prevent any of the medication from leaking down your tear ducts. If you have other kinds of medications, you may notice a bitter taste after putting in the eye drop, and that's a sign that some of it's going down the back of your throat. And finally, you want to carefully blot away any excess liquid that might be on your skin. So now the unwanted extra. Like any medication, they come with side effects. And thankfully, most of them are cosmetic and not harmful, but they can be noticeable. These side effects include changes in eye color, longer and thicker eyelashes, darkening of the skin around the eyes, and eyelid deepening. So while they do their job well, they also give you a couple extra beauty treatments along the way. And so one of the most notable side effects of these prostaglandins is iris pigmentation changes. This is more likely to happen if you have lighter colored eyes. Over time, the iris can gradually darken, but this change only happens in the treated eye, and the color shift is impermanent. The good news is that this color change doesn't affect your vision, it's purely cosmetic. And so on the upper right image, you can see an example of a young child who had latanoprost in one eye and not in the other, and you can see the difference in darkness. And on the image below, you can see a before and after photo of a patient who, first of all, didn't have any of the latanoprost, and then afterwards, you can see that pigmentation changed around the mid-periphery of the iris. Now, what some might call an unexpected bonus of prostaglandins is the longer, thicker, and darker eyelashes that they can cause. And in fact, there is one prostaglandin medication out there called Latisse, which is even sold as a cosmetic treatment for eyelash growth that some people use without glaucoma. And so this growth typically starts within a few weeks of using the prostaglandins, but if you stop using the drops, your eyelashes will typically go back to their original length. And in the image, you can see pretty clearly that from before to after, the eyelashes get much longer and thicker. And another thing is periocular skin changes. So PGAs, they can cause darkening of the skin around the eyes, known as the periocular area. This pigmentation change is more noticeable in people with lighter skin tones, but this pigmentation can sometimes be reversible if the treatment is stopped. So if you start looking a little more tired than usual, your PGA drops might just be the culprit. Now, this one might be a bit more subtle, but still worth mentioning: sulcus deepening, or what some call the sunken eye look. PGAs can cause a slight hollowing of the area around the eyes, and so this change occurs slowly over time and may reverse if you stop using the drops. It doesn't affect your vision, but it can alter the appearance of the eyelids, which might be a cosmetic concern for some patients. And so you can see in this image on the top panel that, first of all, you see the pigmentary changes on the left eye of the patient, but since he's just been using bimatoprost in that eye for 6 years. And if you look from the bottom, you can see just how much more hollowed out that eye is compared to the other one. Usually it wouldn't be such a distinct difference because many patients use it in both eyes symmetrically, but this highlights that stark contrast. And lastly, let's talk about some of the more common side effects like dryness, redness, and irritation. These symptoms are usually mild and tend to improve as your eyes adjust to the drops. But if the discomfort persists, your doctor might recommend switching to a different type of eye drop or using lubricating eye drops alongside the prostaglandins. And so what this image is showing is what we see when we look into the slit lamp. When you go into the eye doctor's office, you may notice sometimes they instill a yellow colored drop called fluorescein into your eyes. And then when we look with a blue light filter, we can see these irregularities and these speckles on your cornea, which tell us that there's a bit of irritation and dryness on the cornea that you may or may not be feeling that could be as a result of the eye drops that you're on or the preservatives that are in them. Okay, so I've talked a lot about potential side effects, but I want to emphasize that these shouldn't scare you. The benefits of prostaglandins, particularly in preserving vision, far outweigh the cosmetic side effects. Most of these changes are reversible and manageable with proper guidance from your doctor. At the end of the day, protecting your vision is the top priority, and prostaglandins are incredibly effective at doing just that. So let me share a bit of my own journey with prostaglandins. Like many of you, I had high intraocular pressure, and I was prescribed prostaglandins to manage it. What I didn't fully expect was the hands-on learning that I'd get with some of the side effects. You can see here, the eyelid sulcus deepened, my iris darkened, and I even noticed changes in my skin pigmentation. Of course, my eyelashes went through quite the transformation too. But most importantly, and this is key, the prostaglandins did their job. They brought down my intraocular pressure, which is the real win in all of this. So let's talk about the good, the bad, and the lashes. The good news is prostaglandins were effective at lowering my eye pressure, no complaints there. The bad news, I had dry eyes, a darker iris color, and some subtle changes in the skin around my eyes, but then there's the lashes. I had some friends seriously asking if I had eyelash extensions, whereas others would ask if I was tired from the night before being on call. You win some, you lose some. So not all side effects are bad. Some can be a bit fun. Now, managing side effects doesn't have to be difficult. My advice, don't panic. Most of these effects are purely cosmetic and manageable. Communicate with your doctor. They can adjust things if needed. And if you get dry eyes, you can use some lubricating artificial tears. And remember to gently wipe off any excess medication around your eyes. The key takeaway is to remember that prostaglandins are effective, they work, and that's what truly matters in the long term. Okay, so what's missing in current research on prostaglandins? Well, most studies focus on how effective they are at lowering intraocular pressure, but what's lacking are quantitative metrics for measuring side effects. A lot of the current data relies on subjective reports from patients or providers. What we need is a more scientific, standardized way to measure these side effects objectively and consistently. That's where our study comes in, attempting to fill in that missing piece of the puzzle. So our study is designed to explore these side effects in more detail. We have 4 main groups of patients. First, we have new patients starting on PGAs. This group will help us observe how side effects develop over time. In the second group, we have patients who've been on PGAs for more than 12 months and are now stopping treatment, allowing us to see if and how side effects reverse once the medication is stopped. Third, we'll have a group of healthy controls who don't have any glaucoma and aren't using any eye drops to help establish baseline data. And finally, we'll have a group of patients using non-prostaglandin eye drops that can be beta blockers, alpha agonists, or carbonic anhydrase inhibitors, or anything else, and give us a comparison point to see if these side effects are specific to prostaglandins or also occur to some degree with other treatments. So in this study, we're using slit lamp photography at each clinical visit to capture high-resolution images of the eyes. This allows us to track changes over time. We're going to be focusing on measurable changes in key areas. We're going to look at iris pigmentation, measuring how the color of the iris changes over time. We'll also track periocular skin pigmentation, monitoring any darkening or lightening of the skin around the eyes. And of course, we're also going to measure eyelash growth. It's one of the more noticeable changes. We'll measure the depth of the eyelid sulcus, which tends to deepen with prolonged prostaglandin use. And lastly, we're going to measure or monitor fluorescein staining. This is going to help us check for any changes on the surface of the eye, such as irritation or dryness. We break down these analyses into 2 categories: measurement analysis for things like lash growth and sulcus growth, and color or texture analysis for iris and skin pigmentation, as well as fluorescein staining. So when it comes to tracking color changes in the skin around the eyes or the iris, we use a special method called C-Lab color analysis. You can think of it as using a more accurate set of glasses to see colors. C-Lab lets us look at the subtle shifts that happen over time. We start by converting photos from RGB, this is how cameras see colors, to C-Lab. And this is closer to how our eyes naturally see them. This helps us capture changes more precisely. And so in C-Lab, we look at 3 things. The first being the L parameter, or lightness, and this tells us if the skin or the iris is getting any lighter or darker. We're going to be looking at something called the red-green shift, which we'll be looking at red shifts due to the prostaglandins, or green shifts from the fluorescein staining, which would be an indication of dry or irritated eyes. And we'll also be looking at something called the blue-yellow shift, which will help us see changes in the undertone shifts in eye color, and especially for people with lighter colored irises. And so using this method means that we can get a much clearer picture of how PGAs might be affecting pigmentation, giving us data that's precise and easy to compare over time. And when it comes to understanding how they affect the skin and iris, we also need to look beyond color changes. And that's where texture analysis comes in. Think of it like using a magnifying glass for the details. This allows us to spot changes that might be too subtle for us to see otherwise. We use methods like hair-like features, which help us identify patterns in brightness and contrast, and essentially looking at how changes in the surface change over time. We also use something called local binary patterns, and these help us detect even the smallest texture changes. And you can see an example of how texture is seen through the computer on the image to the left. So these techniques give us a more complete picture of how prostaglandins might alter the skin and the structure of the iris over time, even if those changes aren't immediately obvious to us. And so in addition to our color and texture analysis, we're going to be manually measuring eyelash length and eyelid sulcus depth using a simple paper ruler. This will give us a precise measurement over time to track changes. And in the future, we're going to look at using computational methods to estimate these values from photos, adding a layer of automation and increasing the precision in our analysis. So this could bring even more consistency to tracking these changes in future studies. So our study is going to follow participants over a period of 12 months. We'll take measurements at several time points. Of course, day one, the baseline, when they're either diagnosed and given eye drops or stopping. And this will give us our starting point. Month one, where we'll begin tracking the changes. At month 3, we'll continue monitoring. Month 6, we'll have more significant data on long-term effects. And at month 12 will be our final assessment to see how these side effects have evolved or reversed over time. We'll also stratify the data by factors like age, sex, and ethnicity to identify any groups that might be at higher risk of experiencing certain side effects. So why does this matter? Well, this study matters because it's all about better care and better outcomes for patients using PGAs. We'll be providing doctors with a more accurate understanding of the side effects these treatments can cause. And with that knowledge, doctors can better inform patients about what to expect so that there are fewer surprises along the way. And ultimately, our study is going to produce guidelines for managing these side effects. This will help ensure that both doctors and patients are prepared, leading to improved overall patient care. So what does this mean for you as a patient? Well, this study will give you a clearer idea of what to expect when starting or stopping these prostaglandins. That means you'll be able to make more informed decisions about your treatment. And by knowing what side effects to expect and how to manage them, you'll be less likely to stop your medication, which is crucial for long-term eye health. Plus, we'll have a better understanding of how reversible these side effects are, which will give you some peace of mind as you move forward with your treatment. So, the future of treatment. Looking ahead, this study isn't just about identifying side effects, it's about improving your care. The insights we gather could influence future glaucoma treatments by setting a new standard for measuring side effects in clinical trials. We might be able to develop better medications that have less side effects, or come up with alternative therapies like certain creams or whatnot that can lessen their impact. With better data, doctors will be able to refine treatments and help patients manage these side effects more effectively. Our ultimate goal is to create a future where glaucoma treatments are not only effective, but also have minimal side effects, allowing patients to maintain their quality of life. So I guess getting to the end here with my final thoughts. As we wrap up, I want to leave you with a few thoughts. The study is more than just numbers and side effects. It's about improving quality of life and ensuring that effective treatments be balanced with the comfort and the well-being of those who rely on them. The work we're doing here today will help shape the future of glaucoma care, hopefully, and provide patients with the best possible outcomes, which is our goal. And so our vision for the future is clear. While glaucoma can't be cured, it can certainly be controlled. PGAs are a critical part of the treatment toolkit, and understanding their side effects help us maintain that balance between effective treatment and preserving quality of life. By understanding and managing these effects, we can protect what matters most, your vision. So staying commitment to your treatment is key. It's a marathon, not a sprint. Glaucoma is a long-term condition that requires ongoing care. It's important to stay the course, communicate with your doctor, and work through any side effects or concerns that come up. Your vision is worth it. So with that, I'd like to thank you all for your time and your attention today. It's been a privilege to share our research with you, and I hope it's offered some new perspectives on the impact of prostaglandin analogs in glaucoma treatment. I want to extend a special thank you to Dr. Matthew, the principal investigator and my mentor on this project. And of course, a big thank you to the GRSC and all the donors who make this important research possible. And so with that, I'll hand it back over to Tom.
Okay, thank you. Thank you very much. Dr. Balas. That was an excellent presentation. I enjoyed it very much, and I'm sure our attendees did as well. And I congratulate you on staying exactly on time. That's terrific, terrific job. Let me continue now with just a moment. Okay, let me get myself on the screen here for a moment. Okay, so we're going into the live question and answer session. We have a panel of experts. Dr. Bindlish will be on the line. Dr. Burt is on the line. Unfortunately, Dr. Hutnick is traveling to a conference right now and is en route and won't be able to make it. But Dr. Ballas will join the panel. And I'm not sure, Graham, if you want to join in, or we'll have the three.
Three is fine.
For now, I think they're well qualified. So I want to just remind you that you can take a look at the top or bottom of your screen. You should be able to find an icon that looks like this with Q&A underneath it. If you don't see it, it might be hidden under a ... more icon where you can pull down, click on the word more, and you should see a line that says Q&A. So during the question and answer session, if you have a question you'd like to add, please just type it in there, click on the Q&A icon, and you'll be able to submit a question. Unfortunately, we are not set up to handle interactive discussions with individuals. I think one person wanted to know if they could ask an interactive question, but I encourage you to submit your question instead. And if you don't get an answer that satisfies you, you can call the office and submit a question to Dr. Bindlish offline, which he'd be happy to answer. So with that, I am going to stop sharing, and I'm going to go right to bring in our panel of experts. Okay, so just give me one moment. So here's Dr. Katie Burt. Here's Dr. Bindlish. And hopefully, oh, I lost, okay, I'm sorry, guys. I have to make you all join together. Okay, just give me a moment. Okay. I just have to get myself going here. I did it before. So here's, okay, here's Katie. Here's that, and here you are. There. Okay. Now you have everybody online. So Raj, you can go ahead.
Can you take me off, Tom?
You're not showing on the public view, Jim. You're good. Yeah.
Okay. So thank you, Tom. Thank you, Dr. Balas. That was a really excellent lecture. It was a great review of glaucoma, which is always very helpful for our supporters. And obviously, it was a really good insight into looking at prostaglandin side effects. We have about 14 questions so far. I just saw, just as the talk ended, quite a few came in. So we'll try and address as many as possible. Now, one question I'm just going to quickly address, and it was seemed like a little bit unbalanced about a lack of women on the board of directors and how that will be rectified. We do have two prominent ophthalmologists as board members, Dr. Katie Burt and Dr. Cindy Hutnick. One of our previous executives who just retired from the board was Renee Wolf, and one of our past presidents was also a female. our board is relatively open. If you are interested in applying and becoming a board member, you're more than welcome to contact Norlin and put your name in. And we would love to balance out the board so it's not unbalanced from the standpoint of we are trying to exclude ladies from the board. It just happens that way, in that only two ladies have applied. So please, if you are interested, you're more than welcome to submit and possibly join our board. So I'm now going to start to go towards the questions. And I'm going to start with actually one that was emailed a little bit earlier today to me. And it was a question about laser treatment and laser treatment for glaucoma. And what are the maximum number of laser treatments you can have to an eye? And I'm going to ask Katie to answer that question.
Well, thanks, Raj. Assuming that we're talking about laser for glaucoma and not other kinds of lasers, because there's many ways it's used in ophthalmology. And then you have to decide whether you're talking about all laser for glaucoma or just the most common one, which is generally called selective laser trabeculoplasty. And then you have to decide whether you divide your treatments into one session or two. Some people will do 360 degrees as a standard treatment. Some people will do 180. So if you're looking at the eye as a circle, you go around half. That's a fairly standard treatment. You do the second half, that would be 2 treatments. Do the first half again, 3 treatments. Second half, 4 treatments. So for me, in my clinical practice, 4 sessions of laser trabeculoplasty spaced out, ideally over several years, would not be unusual. I don't myself often go beyond that and treat a third time, but there's fairly good evidence that a second complete treatment of the 360 is clinically beneficial. So there's no hard and fast number. And in certain clinical situations, we're always free to break the rules. But 4 treatments of 180 degrees at a time is not uncommon. Not everyone needs that many.
Okay, thank you, Katie. So the next question, and I'll pass this off to Dr. Balas. A little bit of a loaded question, but hopefully he might have some answers. What's new in glaucoma research in terms of basic understanding?
That is a bit of a loaded question. There's a lot of new things in terms of basic understanding of glaucoma research, and I suppose new is a relative term. I suppose recent research is focused on understanding the role of the optic nerve and the mechanisms of pressure regulation in the eye. And so one key area is the study of the optic nerve's response to these pressure changes, including how the pressure affects these retinal ganglion cells, these nerve cells directly. Researchers are also exploring the role of inflammation and immune response in optic nerve damage to develop a more holistic understanding of this pathophysiology. And there's new research being done with new genetic insights, helping identify those at higher risk, as well as growing interest in neuroprotection and finding ways to protect nerve cells from damage just beyond lowering eye pressure.
Okay, thank you, Dr. Balas. I think I would like to put in, and I'd hope you'd say this too, there's also a lot of AI research in glaucoma, looking at different models to sometimes predict a patient's pathway for glaucoma and how they may better receive certain treatments over others at various stages of their diseases. So with your AI background, and I look forward to you being part of that escapade moving forward and hopefully coming up with some answers for us. Next question is about lifestyle makes a difference for glaucoma patients, such as exercise or sleeping on your back or your side. So Katie, any thoughts on that?
It's quite a frequently asked question. I think generally there's a fairly reasonable consensus that a healthy lifestyle is good for the eye as well as the rest of the body. Aerobic exercise seems to lower pressure slightly, but more important, might make the eye, the blood supply to the eye stronger, so that the optic nerve is more resistant to glaucoma damage. So even if it doesn't lower pressure, it might be beneficial through other mechanisms. Measuring the eye during exercise is tricky. There have been a few attempts at that. And again, it's fairly well accepted that certain postures, head down positions, downward dog in yoga, spinal inversion therapy, headstands, really increase eye pressure and should be avoided in people, especially those with progressing or advanced glaucoma. I think there was a third point, and it just slipped my mind, Raj. Can you remind me?
Just sleeping on your back or your side, I think.
Sleep. Yeah, thank you. So when you lie down flat, the eye pressure goes up a little. So again, it's difficult research to do, but there have been some work suggesting that if you sleep with your head at a slightly elevated angle, that might be protective. Some people have tried to see whether if you sleep on your right side routinely, whether the right eye being therefore down might have slightly higher pressure in it overnight and have more advanced glaucoma. But as a practical point of view, it's difficult to tell people not to sleep on one side or the other. Face down perhaps could be avoided, but probably the thing that's most supported by evidence is that if your glaucoma is bad and progressing at pressures that seem to be low all the time, consider sleeping with the head of the bed elevated 20 to 30 degrees.
Okay, thank you, Katie. So a question came in with regard to Ontario government changing the rules about optometry visits. They said that glaucoma patients can be seen without charge for 3 appointments, and there are situations where the patients are complicated and require more surveillance. So I'm going to answer this question because this is a little bit complicated. Generally speaking, if you have a very complicated case and require multiple visits, that would more likely be with your ophthalmologist or glaucoma specialist than it would be with your optometrist. So there is no restrictions on the number of visits you have with your ophthalmologist. Now, for a majority of patients, most of them are seen every 6 to 9 months, so 1 to 2 visits a year with testing. So I think that's more than adequate. If you do require more visits, you can do a couple of visits with your ophthalmologist, and you can do a couple of visits with your optometrist. So that should be acceptable. However, if your optometrist is actively managing you, then I think you need to have a discussion with regard to the number of visits that you're having. So I hope that answers that question. There's also another question here about Ocudose, Timoptic and Ocudose in Canada, which is preservative-free timolol. It's not available in Canada, but we can get preservative-free formulations, which can be done through a compounding pharmacy. Moving on, so here's a question for Dr. Balas. Is one of your study groups taking a combination of prostaglandins and non-prostaglandin medication?
That's a good question. No, we're not doing that. We're separating them into prostaglandin only, whether they're starting the treatment or ending the treatment, no drops at all, and then any other kind of drop. We don't want to mix prostaglandin and other drops because, of course, if we find for some reason that any of the other drops lead to any statistically significant changes in any of these parameters we're measuring, then that's obviously going to bias our results. So for now, we're just looking at them independently and making things simpler. In the future, that's something we can explore and see if combining several drops together, leads to perhaps exponential changes or lessens the impact of certain changes. That's something to look at for the future.
Okay. Thank you, Dr. Balas. So another question, talked a little about strenuous physical exercise, weightlifting, karate, which I think Katie has answered. But there was also a second question, and I'm going to put this to Dr. Balas again. The role of AI evolving in early detection and personalized treatment strategies for glaucoma management. So Dr. Balas, can you make a comment on that, please?
In terms of early detection and treatment strategies, I think something we may see in the future of eye care is, you can have these OCT and visual field machines anywhere. You can have them in a pharmacy, for example, and people come in and take their measurements. And we can have AI systems that are almost as good, if not as good as humans, looking at this data and triaging patients based on level of need and then referring them to an ophthalmologist so that we can optimize seeing as many patients as possible, getting patients seen in low resource areas or rural areas, and trying to optimize the pathway of care so that you're never using the AI system alone just in case it does make any mistakes, but you're using it in combination with the ophthalmologist so we can get care to where it's needed the fastest and also prevent any errors or missed patients.
Okay, thank you. I'm looking forward. I have an interest myself in AI, but don't understand it. So I'm looking forward to seeing a lot of models being produced that will look into this. Another question for Dr. Balas, commenting on your great research, but they wanted to know if there are any similar studies related to non-prostaglandin eye drops.
There aren't any similar studies, period, prostaglandin or non-prostaglandin eye drops, which was both, surprising when I was looking into the literature, and I think highlights the importance of doing this in the first place. There's a bunch of studies out there that report subjective changes. You'll have maybe 2, 3 ophthalmologists that'll look at pictures of, a couple patients' eyes and say, it looks darker, it doesn't look darker, but nothing that actually quantifies this change and says, this is the percentage of darkness by this kind of pixel range, et cetera, et cetera. So we're trying to do this specifically for prostaglandins because they're known for having these side effects, but we're also, what the bigger picture is, developing a methodology that can be used for a bunch of future studies and clinical trials in the future so that we're going away from subjective changes to objective parameters that we can now, rather than just comparing eye drops based on intraocular pressure, we can now also compare them on rate of eyelash growth, periocular changes, sulcus deepening, et cetera.
Okay, thank you, Dr. Balas. Next question for Katie. Quickly, do you have a percentage of success? What do you tell your glaucoma patients if they're going for surgery, what the overall success rate is?
Yeah, it does depend a little bit on individual factors, but I think you usually would say that you get success in about 80% of cases, and that can include restarting the use of drops afterwards. So complete success with perfect eye pressure control and no need for drops is not as common as we'd like, but qualified success of good pressure with some drops helping improves the outcome quite considerably. And in the end, it doesn't matter how you get the pressure down as long as you do get it down. Sometimes drops don't work quite enough, surgery doesn't work quite enough, but the two together are great.
Okay, thank you, Katie. I'll keep you for this next question, which I think is interesting. And but it's what treatments are best if the progression of the visual field is not from the periphery, but it's occurring more in the central field of vision. So is there anything that you would recommend for treatments for that type of progression of glaucoma?
Well, I guess the first thing is to make sure you are dealing with glaucoma, because the other major disease of the elderly that affects central vision is macular degeneration. And that will show in decreasing vision and abnormal visual fields. But if that's ruled out or is not a major component, visual field loss close to the center of vision, close to fixation, is more typical of glaucoma that exists with normal pressures at all measurements. So normal pressure glaucoma. And still the only treatment we have is to get that pressure a little bit lower again. And there was a study which looked at that some years back now, but showed that lower pressure is beneficial even when the pressure was normal to begin with.
Yeah, so you mean sometimes maybe if somebody is progressing that centrally, surgery may be an earlier consideration.
Yeah.
Yeah. So, okay, thank you, Katie. There's a question here on an opinion as to why some provincial pharmacare programs cover Lumigan, but not Zymed, and I'll answer that. So Lumigan, Lumigan is by Mataprost. There's two formulations, a 0.01% and a 0.03. 0.01 is the RC combination or formulation. 0.03 was the original Lumigan, which is available as a generic. Now, those are covered pretty much by most of the provincial pharmacare. Zymed is preservative-free 0.03 by Mataprost. It's brand new to the market. And many times when a new medication comes brand new to the market, the government doesn't cover it on its provincial plan right away. It wants to see the impact of the medication. There are also some regulations with coverage in terms of the cost of the medication and the cost to the provincial healthcare program. And that becomes an agreement between the company that's distributing the medication and the government. And sometimes that can create a little bit of a limitation. So that's why it can take a bit of time. We also have an organization called CTAC, or in Ontario, OTAC, and they actually have to recommend to the government whether the medicine should be covered or not. So it is a bit of a process. So it may take, Zymed's only been out for a little bit over a year. It may take another 6 to 9 months or a year before any review and consideration might take place. Sorry, Katie, you going to say something?
Well, I was just saying there's a related product, which is preservative-free latanoprost or monoprost, which has been out for quite a bit longer. And the problem is the preservative-free production is usually a bit more expensive, but the government just looks at the cost on a daily dose basis and doesn't realize that preservative-free availability is actually worth the extra money.
Yeah, and that's always it does come down to a cost issue. So here's a good question on possibility of home monitoring eye pressure equipment, and can people do some testing monitoring between appointments? So Katie, I'll ask you if you can answer that one.
Yeah, it's not widespread. There are devices which can be obtained, which are meant for people to take their own eye pressure at home. The most typical is called the eye care at home. Part of the problem is you could flood your ophthalmologist with, a pressure reading every hour if you wanted to do that, and that's just too much data to handle. But in selected cases, a week or so of taking your own pressure at home to see what's actually going on can be quite useful, and that can be done. But most people haven't bought the equipment. It's not that cheap. The next step is to whether you should be monitoring visual fields at home. And AI and virtual reality software is getting to the point where it might actually be practical to do that as well. I think, Raj, I think you have some interest in that, or some experience with that yourself. Am I right?
So yeah, I've purchased in my office a virtual reality visual field headset, which is quite economical. Is it something I would recommend my patients to buy and do at home? Not yet. I don't think it's there for sort of prime time. I know in Toronto as well, the University of Toronto has a Toronto home perimeter, and they're working on that. And that might become beneficial down the road, but I still think we're a little bit of time away from that. I think the nice thing about VR headsets, they're just patients like doing the VR headset visual fields a lot more than standard visual fields.
You have to be able to interpret both types of fields together. Having one set of data from home and one set of data from the office that don't sort of interpolate with each other will not be helpful.
Yeah, exactly. And that's going to be the limiting step, I think. Okay, so here's a question for Dr. Balas. Patient was experiencing some darkening around the eyes and asked a cosmetician if there was any product that could help. She recommended something called Reversa. So the question is this safe, and is it how effective? So Dr. Balas, have you heard about this product or know anything about it?
That's a good question. I think I am familiar with Reverse. I think it's a glycolic acid exfoliant in combination with vitamin E. Whether it will help at all is up to conjecture. As far as I know, there aren't any studies that have shown any improvement in periocular pigmentation after using any kind of cream. I've spoken to a couple dermatologists about this. Some seem to think that a cream may not be beneficial. Others think that something like a vitamin C serum, which would be a different product, might cause a bit of, it's in certain cases used to cause hypopigmentation. So it'll brighten up the skin. So if you try an over-the-counter vitamin C serum, that may or may not lead to changes. Again, there's no evidence in the literature to support that. And it would be something for us to explore in future studies, applying the same kind of methodology and seeing if it makes any difference with that and other treatments. Funny enough, dermatologists actually use the same kind of ingredient, the same medication for people who have skin hypopigmentation disorders like vitiligo, where their skin is actually brighter. They'll actually put that medication to darken it out and even up the skin. A little fun fact.
Thank you, Dr. Balas. Katie, here's a question. Why is having myopia considered a risk factor for glaucoma?
Originally, I think it was just an observation that people who were short-sighted, myopic, seemed to be at higher risk for developing open-angle glaucoma. There's a theory that the eye structures are a little bigger and a little softer, and there may be less support for the optic nerves, the components of the optic nerve, and so they damage more easily. It's also, the readings may not be quite as accurate if the eye is a little bit bigger or softer than usual. So we may be underestimating the pressure in those people, so they develop the glaucoma and it doesn't get picked up as early. Or there may be some factor that creates an eye that's myopic that also creates a glaucoma susceptibility beyond just the structural size of the eye. So there's a lot of theories, quite a lot of interesting work is being done on that, but it started out as just basically an observation.
Yeah, I agree. And the only thing I wonder is on some OCT testing, myopic people seem to have very thin nerve fiber layers. And maybe you just don't have that same level of reserve. And that's why, yeah, they go on. So hard to know, but just, yeah, it is an observation. And if you are myopic, make sure you do get your eyes checked regularly. Another question for Dr. Balas. If you don't have glaucoma and you use Latisse lash serum, will it affect your eyes or bring on glaucoma?
Well, it won't bring on glaucoma. It uses the same agent that's in the glaucoma medication that we would use to treat glaucoma. So if anything, it would be beneficial, supposedly, if you had glaucoma, but obviously not as good as the eye drop that you would be prescribed. Although it can cause certain issues. And like I mentioned, since it is the same agent, if you're applying it even around the eyelashes, if you get it on your skin, it might cause some darkening around the skin area. If you manage to get it in your eye, it might darken the iris. I believe it's a lower concentration than what would be in an eye drop bottle. But if, again, you're somehow getting in the eye, which you shouldn't be, it can theoretically lower your eye pressure. And if you already have baseline eye pressure, it can lead to some issues, but that would be very unlikely. So short answer is it's no, it itself will not cause glaucoma.
Yeah. I'm just scrolling through some of these questions. So here's one for Katie. Do you have any possible neuroprotective interventions for glaucoma to minimize damage or progression?
I guess the short answer is no. The long answer is healthy diet, bit of aerobic exercise, avoid the head down positions, all the stuff that I talked about a little earlier. Occasionally, some drugs get mentioned. Once in a while, people bring up ginkgo biloba, but the evidence is sketchy. All of these things have some degree of side effects, and nothing is gotten to the stage where we're comfortable prescribing it as a neuroprotective agent above and beyond lowering the eye pressure.
Yeah, and that's basically what we tell everybody right now. Really healthy diet, I think, is really going to be right now the most important. Okay, I'm going to stop there. I think we've covered most of the questions and answers, and it's 8:23 on my clock. I'd like to thank everybody for the questions that they have submitted. If your question was not answered, I apologize, but we do like to keep within a certain time period for this annual supporters meeting, and we're reaching the end of it. If you do have further questions, you can submit them through the website, and I may be able to help answer those questions. We try and ask that you submit questions that are more general in nature and not asking about specific management type questions for your individual case. So at this point now, I'd like to turn the meeting back over to Tom. I'd like to finally thank all the participants and the supporters. Glaucoma research is not sexy in the real world. We're not, but we are competing with other dollars, and we really appreciate your support. And we are one of the only organizations where a large amount of our funds that we raise do go for glaucoma research in Canada, supporting our students, our researchers, our physicians, to really look at many different aspects for the management and treatment of glaucoma. So thank you for your support. Please keep us in mind if you do want to make a charitable donation. And I hope you enjoyed the Q&A session. Thank you.
Thank you very much, Raj. I'm going to, let's see if I can manage this better. There I am. Okay, so we're coming up to the conclusion of our meeting. I'm going to just bring our slide deck back. There we are. And I'm going to introduce Jim Parks again as our president and ask him to provide some closing remarks. Okay, Jim, you're on the screen and you have the floor.
Okay, if you could scroll down through to the last award, please.
There we
There
go.
we are. Okay.
Yeah.
Well, again, Dr. Balas, thanks very much. I'll echo the comments before, and I found that very enlightening. We've had many lectures in the past, and yours is right up there on the par with all of them. So I thank you for that. And I also reiterate the thanks to the panel for their input. Having said that, this is the final thank you. I thanked everyone for attending at the beginning. Those who've stuck with us throughout, I thank you again and hope you'll continue to support us and attend future meetings. One final pitch for the supporting the Walk for Research on Sunday. If you can find it in your hearts to chip in for that, it would be much appreciated. And finally, just reiterating what Tom had mentioned at the beginning, we will be sending out a survey. They're very helpful for those who take the time to respond, particularly about the question and answer session. And we realize we can't answer all the questions, but we do appreciate your feedback and try to factor that in as we go forward with our future meetings. So on that note, I will say goodbye until next year to everyone, and thanks again for participating.